All right, Nicholas, this will be good. So here are our disclosures. The learning objectives today are to discuss how to apply evidence-based guidance to assess the severity and quality of life impact of chronic rhinosinusitis with nasal polyps, or CRSwNP, to describe how to incorporate current guidelines and expert recommendations into the positioning of biologic therapy, sinus surgery, and oral corticosteroids for the treatment of patients with CRSwNP, and finally, to summarize clinical trial data on the efficacy and safety of biologics and surgical options for patients with CRSwNP. So let's start with the disease burden of CRSwNP. We do know that the prevalence of CRSwNP is actually quite high. We think almost 8 to 12% of the population has CRS, or chronic rhinosinusitis. Of this, most patients, about 75 to 80%, have CRSwNP. That's CRS without nasal polyps. About 20-25% have CRSwNP or with NP, which we'll focus on today, which tends to be the more severe variant of CRS, so a very prevalent disease. Let's talk a little bit about disease severity of CRSwNP and the symptoms and impact on quality of life. The classic symptoms of CRS include sinus headache, pain or pressure, anterior or posterior nasal drainage. Especially in patients with nasal polyps, loss of smell is a huge one, and it really impacts them. These patients complain of nasal congestion or blockage. And in addition, they can have other comorbidities and so have other symptoms that are outside their nose. The impact on quality of life, you can imagine if you cannot breathe through your nose, your sleep quality is terrible, you don't sleep as well. You have social impact at social settings, you're tired, don't feel as happy, frustrated, because this is a chronic condition. It affects schoolwork, it affects work, it affects you on a daily basis. So some studies have looked at the impact of CRSwNP more formally. And in this study where you look at SF36 quality of life, looking at physical impact, CRSwNP is in dark blue, RA is in green, type 2 diabetes is in blue, and asthma is in purple. And you could see CRSwNP in terms of SF36 physical impact scores, very similar to diabetes and asthma. When you look at more the mental impact, again, CRSwNP, very similar to asthma, type 2 diabetes. And you could see that the dotted line is the population norm. And when you look at, this is a European Quality Visual Analog Scale, unfortunately, you could see CRSwNP actually has, again, significant impact on quality of life. In fact, worse than in asthma and type 2 diabetes. So when there was a patient interview done on 15 patients with CRSwNP to identify unmet needs in terms of burden of CRSwNP, these patients experienced a major impact of nasal polyposis on their daily lives as a result of all these symptoms. And the most frustrating aspect of the disease was impaired sleep quality, along with the mental dysfunction and reduced smell capacity. It's important to remember that if you cannot smell, often you don't taste as well, so you don't enjoy your meals, which to me is really important thing that we every day rely on our taste and smell for our eating. In addition, when you lose your smell, the other thing that I think is so important, what if there's a fire, you may not smell it, and so it's something for safety as well. In addition, these patients said, underestimation of burden. They were incredibly frustrated about the underestimation of burden of their disease and the importance, again, on the psychosocial aspect, including mental health, sleep quality, and social function. Another unmet need was that there often needs to be coordination of care for these patients with ENTs, allergists, their primary care physicians, and treatment limitation that despite many positive aspects of sinus surgery, which these patients almost always get and often get oral steroids, there are many limitations because the disease can recur and there are adverse effects, especially with systemic corticosteroids. This dependence on needing to take drugs on a regular basis, because this is a chronic condition, and sometimes more than one surgery, restricts patients and impacts their freedom. So let's talk a little bit about assessment of disease severity and quality of life impact. So there are different quality of life questionnaires. The one that's used most commonly is SNOT 22 or Sinonasal Outcome Test 22. It's a 22 item. It's very disease specific. There are many different domains in there. The main domain that is thought to be most important is the rhinologic domain, which talks about the different which includes the different symptoms we talked about, including nasal blockage, congestion, loss of smell or taste, drainage, anterior, posteriorly, need to blow nose, and again, posterior nasal drainage, but it looks at many other things. And many of us use this disease-specific quality of life in clinical practice. Another way to assess disease would be by nasal polyp score. And here you could see there are different ways of seeing the nasal polyps. You look at it in terms of it being in the middle meatus. Is it below the middle turbinate, which you can see on here, or is it get to almost to the floor? Anywhere from 0 to 4 is the score. With the higher the score, the worse disease. And severe CRSwNP typically is defined as nasal polyp score greater than 5. And here you could see the polyp is in the inferior nasal cavity. Here it's more near the middle turbinate. Just it's not reached the bottom of the middle turbinate. So in addition to CRSwNP impacting your quality of life, these patients have many comorbid conditions. And in this graph, you could see on the y-axis is proportion of patients with mild, which is in blue, moderate, which is in green, severe is in red. These are comorbidities seen in patients with nasal polyps. And if you look at allergic rhinitis on the left, atopic dermatitis in the middle, and asthma on the right, these individuals tend to have moderate to severe comorbidities, as you can see by the green and the red. How do you tell and how do you diagnose these that this is type 2 inflammation? You can do it based on comorbidities. CRSwNP is a classic type 2 inflammatory disease with cells that are important, including mast cells, eosinophils, basophils, Th2 cells. Often these patients have comorbid late onset asthma. When they undergo surgery, their pathology will show tissue eosinophils, high tissue eosinophils, typically more than 10 per high power field. Or you can look for evidence of type 2 inflammation based on blood eosinophils, which typically is greater than 150 cells per microliter. In addition, we think of this being a type 2 disease. There's a subset of patients with CRSwNP who have what we call NSAID exacerbated respiratory disease or aspirin exacerbated respiratory disease. In this condition, these people have polyps, often asthma, and if they were to take an NSAID or aspirin, their nasal symptoms get worse, their asthma can get really severe enough sometimes to need to be admitted to the ICU. This disease is a very type 2 version of nasal polyps. In addition to tissue eosinophils, blood eosinophils, total IgE, or allergic antibody, if it's greater than 100 IU per ml, that too also suggests to us type 2 inflammation. So let's move on to treatment of CRSwNP. The typical treatment includes saline rinses, intranasal steroid sprays, or oral steroids. Again, oral steroids have a lot of side effects, so we try and limit this. If patients fail that, then sinus surgery is an option. However, the most exciting thing that has happened to CRSwNP is that we now have newer treatment options, biologic therapies that we'll discuss a bit today. So here's one way of delivering topical steroids. This is exhalation delivery system with fluticasone or EDS flu. And what it does, it gets the fluticasone deeper into the nasal cavity, and you could see it right here. One part goes in your mouth, one part goes in your nose while you push the bottle. It gets in there much deeper, so it's a little more, I shouldn't say a little more, it's more effective than topical nasal steroids that are available over the counter. In their phase 3 studies, and it's actually approved for CRSwNP, there's improvement in quality of life as well as improvement in sinus CT scan. And this is actually approved not only for CRSwNP, but also for CRSwNP. It is quite well tolerated. The only side effect to note of concern is at least in 2 sprays twice a day, you can get more irritation and sometimes epistaxis. Now, we talked about sinus surgery being something that is an option for these patients. Unfortunately, studies have shown that up to 40% of people with nasal polyps, after they undergo surgery, their disease may recur. There are studies that have looked at what are the risk factors for recurrence of disease, and these include if you have comorbid asthma, individuals with CRSwNP who have aspirin-exacerbated respiratory disease, a subtype of CRSwNP called allergic fungal rhinosinusitis, where fungi causes a lot more inflammation, smoking, those who have allergic rhinitis, those who have type 2 inflammation. And remember, we talked about you can tell you have type 2 inflammation based on blood or tissue eosinophils, high IgE, and comorbid asthma. Those who have previously had surgery in younger individuals all have increased risk of recurrence after surgery. So this is the chart showing the different biologics that are approved for CRSwNP currently. These include dupilumab, which targets IL-4 and IL-13, classic type 2 cytokines. It's approved for individuals greater than 12 with the inadequately controlled CRSwNP, and its typical dosing is 300 milligrams every 2 weeks injection. Omalizumab, which targets IgE, the allergic antibody, one of our oldest biologic. It's indicated for individuals over 18 who don't respond as well to topical steroids. And the dose is either dosed every 2 weeks or every 4 weeks, depending on weight and IgE. And then meplizumab targets IL-5, another type 2 cytokine. This is indicated for adults greater than 18 with inadequate response to intranasal corticosteroids. And this dosing is 100 milligrams every 4 weeks. So we have 3 of them dosed between every 2 to every 4 weeks. And here is actually a table that was published a couple of years ago, and it was by Paul Oikman from Canada. And we used this paper as a technical document for our practice parameters, which are our guidelines for treatment of CRSwNP. Here, the guidelines compared the 3 biologics as well as aspirin. Aspirin desensitization can be used as a treatment for patients with AERD. In this table, you can see they looked at patient-important outcomes as well as surrogate outcomes. They are both important, but patient-important outcomes could include quality of life, symptoms, smell, need for rescue oral steroids for severe disease, need for polyp surgery. AEs are adverse effects. On the right-hand side, looking at surrogate outcomes are polyp size and CT scan scores. Dark green means the most beneficial. Red means most harmful. Light blue is immediate beneficial. Dark blue is least beneficial or not clearly different from placebo. And you could see among the 3 biologics, the one with the most dark green is dupilumab across all of those patient outcomes, and then omalizumab and meplizumab as well. In terms of adverse effects, these biologics are very well tolerated. The only one with adverse effect is really aspirin desensitization. And then in terms of polyp size and CT scan scores, also the one that shows to be most effective is dupilumab. There are also studies looking at real-world efficacy of these biologics. They improve quality of life with SNOT 22. Remember, we talked the disease-specific quality of life questionnaire. They improve congestion. They decrease polyp size. They improve loss of smell. Decreased need for steroid, depending on which one, dupilumab and meplizumab do. Asthma control is improved with all 3 of these. They're all approved for asthma. They show decrease in asthma exacerbation, which is, again, a very common comorbidity in patients with nasal polyps and often severe asthma. So in terms of treatment selection and what are our goals of treating CRSwNP, this is a document that came out of a meeting we had in Belgium. Euphoria is a not-for-profit organization made up of allergists, ENTs, pulmonologists, mostly European, a few of us from US, where we looked and defined how we define control, how we define remission or cure. And you could see that control and remission is on treatment, while cure is a goal, a lofty goal that we strive for. Most of these patients get controlled and remission. And remission we define as, which we also try for, we would like for them to go on remission, which is having no symptoms, no endoscopic evidence of inflammation for greater than 12 months, and of course, no surgery and no systemic steroids. How do we decide how to treat these patients? There are guidelines, both through Europe as well as in the US. This is a guideline called ACCME yardstick. This was a consensus document that we put together. There were ENTs and some of us allergists, and we said in someone with chronic rhinosinusitis, which by definition is symptoms being present for more than 12 weeks and evidence of inflammation, the first line of therapy for all, whether you have with or without polyp, is topical nasal steroids. And if it doesn't work with the over-the-counter sprays, we would say change the delivery and often nasal saline irrigation. If that doesn't work, you want to phenotype them much better. You want to endotype them mostly based on history, the comorbidities, eosinophil counts, IgE. You could do a CT scan or endoscopy or both. And if they have with NP, the type 2 type disease that we're concerned about, most of these people, if they still have symptoms despite different delivery systems of topical steroids, irrigation, then typically undergo sinus surgery, sometimes biologic, depending on if they're not a candidate for surgery or have other comorbidities or have severe asthma, occasionally oral corticosteroids courses, but you really don't want to use too many of these. And the group with AERD, the most severe variant, same thing. Endoscopic sinus surgery, biologics, need for oral steroids if really needed for short course. This, you have the option of aspirin desensitization that we talked about. These individuals need to then stay on aspirin long-term. If they go off more than 48 to 72 hours, they need to be desensitized again. Leukotriene antagonists are also an option for these patients. Another multidisciplinary management algorithm, this is mostly ENTs. There were some of us allergists. In most people, this algorithm says sinus surgery. Post-op, they say if you have symptoms, and remember 40% of people's symptoms may recur, then consider biologics, revision sinus surgery, aspirin desensitization, steroid implants. These are local steroid implants that can be put in place, or a short burst of oral steroids. For biologics and aspirin desensitization and revision surgery, whatever is done, these patients often have chronic disease, so you need to assess response, change what you're going to do if something's not working. Some people, according to this algorithm, those who have contraindication to surgery, those who have severe asthma, or those who don't want to get surgery, it's shared decision-making between healthcare provider and the patient, then you could consider biologic even before surgery. This is our European guidelines from Euphoria. They recommend in someone with, when would you choose biologic in someone with polyps? You want to make sure it's bilateral, because if it's unilateral, you have to worry about other things that look like regular old polyps, including malignancy. So in someone with bilateral polyp who's had surgery, they recommended 3 criteria, including evidence of type 2 inflammation, need for systemic steroids or contraindication to systemic steroids, significantly impaired quality of life, significant loss of smell, or comorbid asthma. On the right-hand side are the different criteria you can use to look for type 2 inflammation, how many courses of steroids, so anyone with getting more than 2 per year or steroid dependent. Quality of life you do based on SNOT-22, and then asthma, as you can imagine, based on history, or PFTs, and regular need for inhaled steroids. So how do you decide the right biologic? Really, the first thing is confirm the diagnosis of severe nasal polyps, check for comorbidities, determine if it is type 2 inflammation, then talk about the different treatment options with the patient, topical steroids, different delivery systems, surgery, biologic, both. And then decide based on shared decision-making after you go through all the evidence, risk benefits, and then you may decide either surgery or biologic. or sometimes both. So we're going to move on to case presentations and discussion. And Dr. Kalinsky is going to now take over. Let me know.
Sure. Thank you so much, Dr. Peters. That was really informative, great presentation. So here we have a real patient that I actually saw in clinic, of course, de-identified. This is Peter. He's 30 years old. He travels frequently for work. He moved to East Tennessee, which is where I'm from, 2 years ago. 5 years ago, he was diagnosed by an ear, nose, and throat physician with CRS with nasal polyps. We were unable to obtain those records. He came in absolutely desperate, congestion, couldn't sleep, always sounded really nasally, had a ton of drainage, had a lot of facial pressure, sinus pressure and pain and discomfort. He'd been on multiple rounds of antibiotics and steroids over the course of the last 12 months for a sinus infection. But what bothered him the most was his decreased sense of smell. He didn't enjoy simple things like eating or going out to eat. And even since going to Tennessee, he has actually had those symptoms worsen over the last 2 years. As far as his other medical history, he has a history of allergic rhinitis. He was diagnosed as a child. He also has a history of uncontrolled asthma. He's been on high-dose ICS/LABA, but using his SABA often, and he's required multiple rounds of oral steroids. He also has a history of atopic dermatitis that is not controlled. He's failed multiple over-the-counter medications for all these conditions, including Singulair, nasal rinses, high-dose nasal steroids, antihistamines, oral antihistamines. He hasn't been offered surgery to this point. As far as his environment, he also has a cat and a dog at home. Next slide, please. So clinical findings on exam, he had allergic shiners. When I looked in his nose, he had edematous nasal mucosa. His septum was deviated to the left, and you could actually see nasal polyps in the right nares. He wasn't wheezing on exam, and he did have lesions consistent with atopic dermatitis. His primary care had ordered a CBC with a differential, and the absolute eosinophil count was 400, IgE was 300, hallmarks of a Th2-driven disease. We also did pulmonary function testing or spirometry in the office. He had a post-bronchodilator response of 10% reversibility in FEV1. We skin tested the patient, pan positive, trees, grass, weeds, cat, dog, dust mite, mold. So an allergic individual. We also have the ability to check FeNO or fractionalized hale nitric oxide in the office. His was low at 16 for an adult, typically greater than 25 is elevated, or a child greater than 20. Next slide, please. So we also have a CT scanner in the office. We did a CT. He showed chronic significant pansinusitis. It looked absolutely horrendous. The overall impression, pansinusitis with nasal passage changes consistent with a history of CRS with nasal polyps. It wasn't actually explicit as far as mentioning the nasal polyps. And so I do have the ability to do rhinoscopy as well. So we rhinoscoped the patient, and on exam, I saw purulent drainage coming from the middle meatus. It was noted bilaterally. And this is important for documentation, both to grade severity, but then also so the insurance company can see how severe the nasal polyps are to describe this with this type of verbiage. So I put large nasal polyps extending beyond the border of the middle turbinate. So we saw in the pictures earlier, that would be at least a grade 2 on each side. But then this is the kicker that jumps it up to a 3, medial to the middle turbinate, but not obstructing the nasal cavity completely. So not quite a 4, but a 3 on each side for a cumulative total of 6. And of course, this patient was diagnosed with CRS with nasal polyps. Next slide, please. So this is a polling question, so A, B, and C. What is Peter's CRS with nasal polyp severity? Mild, moderate, or severe? And I believe you actually have the ability to answer this question.
Excellent. We're starting to see people voting on this.
Perfect. So far, most people say severe. I think there's more people in the chat than 6, though, so.
All right. I think we would agree that this person's polyps are pretty severe.
Definitely. I think, if I can get this off my thing. So I would totally agree. And generally for me, whenever I'm grading a person's nasal polyps, I'm looking at that nasal polyp score. It's something that I can objectively measure while the patient's in the office. Again, I think that the ability to do rhinoscopy is extremely important. And so the score was greater than 5, which would be consistent with severe, correct? Then we can go to the next slide. So what are the indicators for severe disease for Peter? And then what other information can help with severity assessment? So like we had mentioned earlier, we have the nasal polyp score. Dr. Peters, do you have an opinion on any other information we can use for severity assessment?
Yeah, I think nasal polyp score, some evidence of endoscopic evidence of inflammation is very important. I do think a CT shows severe disease too. So once you see the polyp, the CT is that bad, then you can do what's called Lund-Mackay score, and you can grade it from 0 to 24. That could show you severe disease. You also can do quality of life questionnaires like SNOT 22, and the higher the score, the more severe disease. The fact that this person's needing oral steroids, oral antibiotics so often, these are all indicators, I think, that are really important to document, as you mentioned, because you may need more treatment than just what he's on because it's obviously not working.
Definitely, I totally agree. And I think that that's not 22. The patient's score would have definitely been greater than 50, which is, I believe, consistent with severe disease. I mean, he was absolutely desperate. It's hard to get a 30-year-old male into the office to see you sometimes. And so he wouldn't be there unless he was really struggling. But I completely agree.
Yeah,
Next
and you know,
slide.
all his symptoms, his loss of smell, all of that, his asthma not being controlled, we think of it as, at least all of us who are allergists, think of it as unified airway. And if your nose is not controlled, your lungs are not controlled. And studies have shown that in severe asthma, almost 1/3 have nasal polyps. And often when upper airways are exacerbated, lower do. So there are many ways. I think, Nicholas, your patient, definitely very severe, as you mentioned.
Definitely. So another polling question, in addition to optimizing
Oh, can you read it? Let me see.
therapy, I can, it's okay.
All right,
I'm
let me
almost
see.
there. In addition to optimizing therapy for asthma, allergic rhinitis, allergic conjunctivitis, and atopic dermatitis, what would be your next step in treating Peter? So a course of antibiotics, antibiotics with oral corticosteroids, antibiotics, oral corticosteroids, and surgery, or no surgery and do a biologic. So we're getting kind of mixed between the bottom two, surgery and a biologic. I think depending on the situation, both could be reasonable.
I agree. You know, but remind me, had this person had surgery previously or no?
He had not, and he had never been offered surgery either. His last ENT appointment was 5 years ago, so he had been some time and honestly had been absolutely miserable for a number of years.
It appears that most people chose antibiotics, oral corticosteroids, and start a biologic. Some did say antibiotic, oral corticosteroids, and refer for surgery evaluation. I think either one or both are actually would be an option.
Right, and we'll see what I did here upcoming.
Want me to go move forward?
Sure. So how should treatment priorities shift for a CRS with nasal polyp patient with poorly controlled asthma and atopic dermatitis? So for me, you're looking at the whole patient, all these comorbid conditions. You're not going to just treat one. Ideally, you'd like to treat them all. And in a situation like this, it might be very beneficial to consider a biologic that could treat them all or that does have the indication to treat them all. So I think that's reasonable. Of course, realizing that CRS with nasal polyps is a medical problem more than it is a surgical problem. I think that, like you had said, if 40% of the time these nasal polyps grow back, I think that just the united airway and somebody having really difficult to control asthma, I think that addressing the nasal polyps will also help with asthma control. And so I think that this is really important to consider all these different factors when making a decision as far as treatment.
I completely agree with you. I mean, this person's got asthma that's not controlled, have eczema. So either one of those options would seem okay to me. Should I move your slide?
Sure. Can do next slide.
I think we may have lost her. I have the slides
Okay.
up if you want me to share, or I don't know if you want to
Sure,
share.
that would be great if you don't mind, actually.
Okay. Just give me 1 second.
While you're doing that, I think it's just important to realize that, when the patient's coming to see you, it would be nice if they can come in for a one-stop shop, right? Like, so he came in for his nasal polyps, But then because he has nasal polyps, of course, I'm going to pay attention, does he have asthma? A lot of these nasal polyps that are severe like this are also going to have comorbid asthma. And then you need to think about the atopic individual, do you have eczema? And so it's like a young child that might have eczema, and then I'm going to see that family history of parents having asthma. I'm going to ask the question, do they cough in the middle of the night? If they get sick, do they continue to cough for weeks or months? So just kind of dig into the history. Sometimes the patient doesn't always volunteer that information to you, but I think that treating the whole patient, not just one condition, is extremely important. Thank you for pulling this up, and then you can go to the next slide. Okay, so what did I do? So the patient was started on an antibiotic. I chose Augmentin 875 twice a day for 14 days because I saw that purulent drainage on rhinoscopy. Started the patient on prednisone, 20 milligrams twice a day for 5 days. He had a really heavy polyp burden. I was worried that his sinuses weren't going to be able to drain. He had complete opacification of multiple sinuses. And then also by decreasing the size of those nasal polyps, I felt that that high volume saline rinse with the budesonide was going to be able to get where it's supposed to go, to decrease that inflammation, get rid of the infection, and then also decrease the size of the nasal polyps. I recommended an ENT evaluation for surgery. And then also at the time, I was really aggressive and decided to start the biologic that day as well. So we did the entire workup and wanted to start the biologic. Because of the patient's comorbid conditions and atopic dermatitis, severe asthma, virtually steroid-dependent history, and nasal polyps, I recommended anti-IL-4 receptor alpha biologic. However, using shared decision-making and after going over the patient's different options, Peter preferred the Q4-week dosing and was started on an anti-IL-5 agonist, against recommendation for his nasal polyps. As far as his comorbidities, for his asthma, of course, he was started on the biologic, as well as continue the high-dose ICS-LABA, and then I added an ICS-SABA combination inhaler as well. He was really allergic and had an allergic history. His history matched the testing, right? So he had a cat and a dog. His symptoms worsened acutely during the pollen season, so I felt like he would do well on allergy shots. And then for his atopic dermatitis, he was given a topical steroid and then was also educated on atopic dermatitis as well. Next slide. So I saw Peter again in 3 months, and he did go see the ENT and was offered surgery. However, Peter declined because of the cost, which I think happens frequently, or it's something to be aware of when you're sending patients for surgery. He also was doing better as far as his asthma. His allergy shots were going well. His atopic dermatitis was behaving like atopic dermatitis and kind of coming and going, improving on the topical steroid, but he was frustrated with the side effects of using topical steroids, and it wasn't a permanent fix. But his primary complaint was that he just didn't have his sense of smell and taste. He still wasn't sleeping well. He still sounded nasally all the time, was worried about getting infections. He had this persistent sinus headache and pressure, and he had a lot of drainage still. Next slide. So what would you do based on Peter's biologic response at 3 months? So we have A, B, and C, reassess in 3 more months, switch to the biologic, or stop the biologic. I don't know if anyone has the ability to answer like we did earlier. But all three, I think, are interesting options. Here we go. Okay, so the majority are saying to consider switching the biologic and then also consider reassessing in 3 more months. So large majority say switch the biologic. Okay, thank you.
Thank you so much, Nicholas, for taking over. But yeah, I don't think I can forward the slide right now.
I think we're going to get some help.
Let's see if I can. I'll try. I don't think I can forward it. Well, while we wait for it, we can definitely discuss this one. I mean, you know, this person's got severe disease. They tried a biologic, and we sometimes see it that one biologic may work and in a person or not. I think giving it 3 to 6 months makes sense, and then potentially switching.
Right. I think I definitely agree. If we can get hopefully to the next slide, we'll go over kind of what decision we
There
made.
we
There we
go.
go. Okay. So like you had discussed earlier, so evaluating response to biologic treatment. So in Euphoria, the 2023 update, they talked about defining response to biological treatment in CRS with nasal polyps. You have evaluation criteria 5 on the right, or on the left, sorry. You have reduced polyp size, reduced need for systemic oral corticosteroids, improved quality of life, improved sense of smell, and then reduced impact on comorbidities. A score of 4 to 5 would be good or excellent response. A score of 1 to 3 would be poor to moderate, and then 0 would be no response. And then here they suggest to consider evaluating treatment response at 6 months, and then if they have no response, then discontinue the treatment, or you can consider waiting all the way out to a year and then evaluate the patient and then discontinue if they have no response. Next slide. So here's what I did. So in a 3-month follow-up, we decided to continue for 3 more months and then reevaluate. You know, the patient had already started on the biologic. They had some improvement, and I'm an optimist. I wasn't sure if we were going to get some more improvement. So we had continued at the 6-month follow-up. Since starting the anti-IL-5, he still had no improvement in smell and taste. He was kind of frustrated. He almost felt like he was doubting me as a provider. And so I decided to scope him again. He still had significant polyp burden bilaterally. He still didn't have that quality of life he really wanted. He still felt miserable. And the decision was made to transition the patient from the anti-IL-5 to the IL-5 receptor alpha biologic. Then literally 3 weeks later, this patient, I told him to reach out to me. 3 weeks later, he calls the office and says that he's regained his sense of smell and taste. His congestion is the best it's ever been to recent memory, a 2 out of 10. It was an 8 out of 10 when I first saw him. And he hasn't had any sinus infections. So he's doing a lot better and the patient's happy. Next slide.
And I think that makes sense, really, right, Nicholas, based on the practice parameters, the technical report from Paul Oikman. All 3 are approved and all 3 show improvement, but the one that seems to show the most, especially for sense of smell, tends to be dupilumab.
Definitely. And I think that if I'm trying to chase that sense of smell, I find most often I think the biologic is the best way to go, at least addressing the sense of smell. So some of the discussion questions. So what are the key points we can take away from this case? And then in a scenario like Peter's, when costs or patient preference may take precedent over optimal therapy, how would you approach shared decision-making? Dr. Peters, I'll let you kind of go first.
I'll tell you what I do, and I see a lot of these patients. You know, I was the chair of the practice parameters guidelines on it. I think shared decision making is very important. So what I do is I go over all of the evidence we have. I often actually show them that table that I showed you guys. I go over it. I show it as green being the best benefit. I explain it the same way. I figure out from a patient what's more important for them. If smell's important, as you mentioned, biologics tend to do very well. If cost is an issue, surgery can be expensive, biologics are expensive. Almost all patients, I feel like they should get evaluated by an ENT to see if at least one surgery is an option. We go over how the medicine's given, how often it's given, just like you did. If someone doesn't want an injection every 2 weeks, we try every 4-week one. But really going over the best evidence, all the risks, all the benefits, and realizing that costs are a big issue.
I think that's fantastic. I couldn't agree more. I think that some of the key points that I like to highlight is, you know, getting a really detailed history, a very thorough physical exam, looking at every objective measurement that you can take, going through the history, getting the CT scan if you have access when appropriate. I think that the ability to do a rhinoscope in the office is really valuable. And then, of course, skin testing the patient, looking at comorbid conditions. And it's that collective effect of getting the biomarkers that helps you make the decision of which biologic you want to pick or which one you think is the best. You know, if you treat each patient like they're a family member, of course, you're going to want to put them on the best medication out there. I think it's important to also inform the patient, like you said, using shared decision-making, letting them know their options, but why you think this one may be better than that one. is, I think, really important for these patients. And then, of course, thinking about cost and other factors as well, I think are really key when you're coming up with a treatment plan. So thank you. Those are incredible points.
I completely agree with you, Nicholas. One thing I will bring up, not all allergists have a rhinoscope available. If you do, it's excellent. If not, work closely with an ENT colleague, so that you can, and collaboration is key to a condition like this where there's so many comorbidities and severe disease. Next slide.
I completely agree.
Summary and key points. We'll move to the next slide. So it's important to remember there's a very high symptom burden in patients with CRS with nasal polyps, which is detrimental not only to patients' physical, but also to psychological well-being. It is a chronic condition based by definition, so affects someone on a daily basis. The effective disease management necessitates an accurate evaluation, as mentioned by Dr. Kolinsky. You want to establish disease severity, identify comorbidities, determine level of disease control to guide optimal treatment selection based on endoscopy, based on CT scan, quality of life questionnaires. Surgical intervention is recommended and can be effective for patients with uncontrolled disease. However, 40% of people, polyps may recur. And especially if they're symptomatic despite surgery, then we do need to think about biologics, which are safe and effective for patients with moderate to severe CRSwNP and often treat other comorbidities. They're a good alternative to repeat surgeries and systemic steroid treatments for patients with poor disease control. Systemic steroids really have long-term side effects, and we should be mindful of that. Next slide. And with that, we will end. Thank you very much. Don't forget, do your pre and post tests, and please for the CME as well.
Thank you.
And I think on the chat is the link to get the CME. What? And I think we are done, Dr. Kolinsky. It was nice working with you again. And nice
Of course, as always, fantastic seeing you. Thank you all so much. I appreciate your attendance.